Hey everybody, it's Dr. Eric Balcavage. We're back for another edition of the Thyroid Answers podcast, and today we have another guest. We have Dr. Jacob Teitelbaum. He's a medical physician, but I think he's more focused in along the lines of more of a functional practitioner these days. So we're going to talk to him. He's got a book out called From Fatigue to Fantastic. I think this has been the fourth edition is the one I got, so I'm guessing this is going to been updated a few times. He's got some other books, but we're going to talk to him about thyroid physiology, chronic fatigue syndrome, fibromyalgia, and we'll kind of get into a discussion about his perspective on some of those disorders, why people struggle with those issues, is there any relationship to those, and maybe some of the challenges with maybe the interpretation of labs and how the the allopathic model looks at thyroid physiology and some of these conditions and where he may see some problems. All right. So Dr. Teitelbaum, welcome to the Thyroid Answers podcast. How are you doing today?
Eric, great to be with you and with your viewers. And for those of you out there who have fatigue, who have pain, who have thyroid issues, or who treat it, I think we're going to rock your world today. So let's have fun with this.
Okay. So first of all, probably a good place to start is who's Jacob Teitelbaum, right? You're an MD, and typically when we're talking about thyroid physiology, a lot of people have already been to medical doctors for thyroid physiology. They're struggling with chronic hypothyroid signs and symptoms despite being medicated. They may even be experiencing both hyper and hypo. They go from endocrinologist to endocrinologist, thinking they're getting the specialist, the best one. They're getting a TSH with a reflex to free T4. They're given the same medication. They're told everything's normalized. You don't have a thyroid condition anymore. Everything is good. Why are we listening to you, another medical physician, giving us some advice on thyroid physiology?
Because I may be one of the first ones here who actually has a clue what they're talking about with it. I was on the other side of the white coat, Eric. In med school, I came down with a nasty post-viral chronic fatigue syndrome. It actually knocked me out of med school and left me homeless for a good part of the year. And the professors are all sweet and well-meaning and absolutely friggin' clueless. I was going to go into endocrinology as my specialty when I realized, because the research in endocrinology is one of the most powerful areas that's out there in medicine. And the application of that research is a good 50 to 75 years behind the data. They are in the medieval ages. I realized my first month of doing my endocrinology rotation that these people have their heads stuck so far up their butt that they were not going to see light in my lifetime. I realized I could do better endocrinology as an internal medicine physician, and that's a path that I took. But like I say, being on the other side of the white coat, not just as an eye-opener, it's how I learned how to recover myself. And having thyroid issues, because I had major thyroid issues, is a significant part of the whole chronic fatigue, pain, and fibromyalgia process. So I think we have a lot to teach each other today. I think we're all students and we're all teachers. Let's jump into it and see where it goes.
Yeah, so let's talk about thyroid physiology, and from a medical perspective, where do you see maybe the biggest faults or problems with how we assess thyroid physiology from a medical perspective?
Well, number one, they'd rather the patient or the person stay home and just send a blood test. They don't bother actually listening to the symptoms. The symptoms are irrelevant. If the TSH, which is a horrible test, which misses a vast majority of people with thyroid issues, if it's normal, I don't care if you're bedridden. They figure no problem here. And I'll lecture to 400 docs at a time. And I love asking them this simple question, which is, where does the normal range come from? And most of us in med school got the impression that there's a group of wise elders with long gray beards and long gray hair that sat around and looked at all the research and took all the thousands of combined years of patient experience and said, well, if it's in this range, then there's no problem. There's nothing to worry about. No such thing. The normal range is you take 100 healthy people, you do the test, and the 95 in the middle, called 2 standard deviations, is defined as abnormal. So let me put that into easy English. If I had a normal range for shoe sizes, it would be size 5 to 13. Now, I'm guessing, Eric, I know I wear a size 12. I don't know your shoe size, but just a hunch, if I put you in a size 6, it would not work for you. But the doctors would say your size is a 6. It's in the normal range of 6 to 13. There's no problem with your shoe. And that is an utter crock. That
Yeah.
doesn't work for people.
Yeah. So, and when we look at lab reference ranges, I think there's a host of issues, right? And especially, and
Yes.
if you look at some of the scientific research, I mean, there's papers actually that state that TSH is the one and probably only test needed to assess thyroid physiology, which is a crock. But we also have a problem in functional medicine because we have functional medicine practitioners trying to state that the optimal range for TSH is between 1 and 2. And my issue with that is based on what? Because we can't look at a value in a vacuum all by itself. If you're older, you probably need a higher TSH. If you have low T3 in the circulation, you need a higher TSH. That's a part of what helps stimulate the thyroid gland. So I think the reference range, and I think we both would agree that the reason the reference range is established the way it is because from a medical perspective, and I came from that world, the goal is to diagnose the disease and then treat the disease. It's not what we typically think about in functional medicine, which is, hey, can we catch this thing as it's becoming problematic?
Yeah, well, here's the thing. I mean, if somebody comes into my office and they say, my shoe hurts, I'm going to go back to that analogy because it's pretty spot on. I'll do a shoe size. I'll check it. But, and if it's a size 22 and they don't have a big clown nose, or it's a size 3, I think that tells me a lot. But it just gives me where they are in the general population. 90+% of the information I'm going to get is, are you tired, achy, weight gain, cold intolerant, have high cholesterol? Do you have the symptoms of low thyroid? And then how do you respond to various forms of thyroid hormone? Do you get better or worse? And that's going to tell me the diagnosis. The lab testing, it's one piece of information, but it's less than 5 to 10% of the information needed to diagnose and treat thyroid, in my experience.
Well, yeah. So I'd probably disagree with that, but I think the problem is that it depends. The thyroid panel and all the tests have a value, but they all have to be interpreted. Right. And so if you're just looking at values for, are they within a range, a lab range or a functional range, and you're not understanding them in context with the rest of a lab panel, somebody's signs and symptoms, somebody's medication, somebody's supplementation, then you're treating numbers, which is part of the problem. But when we interpret the labs, we need to, my opinion is that we need to understand like what's going on. So I think we have to look at a panel. I think they give good information if we interpret them well, but I don't think oftentimes we do a good job of interpreting labs, which is a huge issue.
I think we're saying the same thing. And it's way more complex than T4 and hypothalamic function with TSH. You have to look at conversion to T3, T3 resistance. There's a whole host of functions that are going on. The effect of the thyroid on adrenal, there are adrenal fatigue or other issues going on. It's not a this than that. It's more of looking at the whole process.
Yeah, and I agree with that. When I try and educate people when I'm teaching or I'm talking to my clients, I tell them what gets measured gets managed. If you don't measure it, you can't manage it, you can't understand it. But what happens a lot of times, and especially in an insurance-based world, is we don't have a drug or a treatment for that, so it's not medically necessary. But to me, it's clinical important, and the bigger the picture you give me, the better I see it. I always tell a patient, if we only ran a TSH, we'd rip one page out of the book and I'd ask you to tell me what the book's all about, and you'd get one interpretation. If I only run a thyroid panel, then maybe I've ripped 2 pages out and I'm asking you what the book's about. But to really know what's going on in your chemistry, I need to read the book, which means I need to look at that blood panel in context with a lipid panel, with my inflammatory markers, with my blood sugar markers. And so we can say, do I have glandular hypothyroidism? Do I have tissue hypothyroidism? Do I have inflammation that makes that a potential normal process, right? An adaptive process. And then what tissues are impacted? Is my renal system impacted? Is my adrenal system impacted? Is my blood sugar regulation? Is my lipids and cholesterol? If you don't have all that stuff, then you become relegated to just trying to manage a lab value. And that's where I think the biggest problem is.
Well, I agree with everything you said, except that at the top of that list, I'm going to add listen to the person.
Oh, absolutely. You have to look at that lab panel, like I said at the start, in context with health history, health timeline, signs and symptoms, and their medications and their supplementation. And oftentimes somebody will send you or me a set of labs and say, tell me what you think. Okay. What were you taking? I mean, what supplements, what medication, what was going on at that time frame? What TSH and T4, that's all you're giving me? I have no idea what's going on, right? So the bigger the picture, and I try and tell my clients, I'm sure you do the same, the more, if you don't give me much data, I can't give you much information back, right? So the health history, the health timeline, probably the two most important things when you're talking to a patient. And usually you get one of two extremes. It's either the person's got a timeline that's 27 pages long and well detailed, or it's 4 lines that encompasses the last 55 years of their life, right?
Well, kudos that you mentioned timeline, because looking for that smoking gun and when symptoms happened relative to what is so critical, and I find generally ignored.
Oh yeah, I mean that you can see the process coming.
Yeah.
So let's talk about your crisis and thyroid physiology. I think it'd be, let's start with what you think happened to you that caused a thyroid issue, and then we kind of dig into there and maybe talk about how thyroid physiology works a little bit and see where we're at on this.
Sounds good. So this is back in 1975. My dad had died when I was younger. I was in medical school at the time. I realized that you pay the same for 1 year of college as 2 years if you're doing 30 credits in a semester instead of 15. Price is the same, paying my own way. I just rolled through college in a little over 2 years for most of my credits while working full time and doing the rest to pay. And that was the easy part of my life. And what was stressful for me in med school, and I was like the third youngest or second youngest in the class, about 350 people, was that, and I was, again, working as a nurse in Children's Hospital to pay my way through, rolling through the whole thing. No big deal. My background, though, is I came from an old Hasidic European Auschwitz concentration camp family and community. And it was a little bit like growing up on the outskirts of a 1500s mountain European town on the outskirts of Cleveland. And it was a very insular community. And when there was a problem in the family, somebody was marrying somebody not Jewish, they decided to move the war ground to my living room and manipulate everything they could. My uncle literally had a heart attack in my living room while trying to manipulate me into manipulate. So there are a number of stresses going on in life that at that point tipped the energy level down, tipped my limbic system and autonomic system towards the edge, had many things. And then I got what I call the drop dead flu. It's a nasty viral infection. And in my case, suppressed the hypothalamic pituitary axis and the limbic system. Is basically post-viral chronic fatigue syndrome and fibromyalgia. And that triggered the adrenal, thyroid, unmasked candida. And since I was paying for my own food with not much money and eating utter junk with that, nutritional, there are a number of things that caused the energy crisis. And that tipped basically a central, initially hypothyroidism. It developed Graves' disease later. But the initial process was hypothalamic pituitary from major stress, which then was basically post-viral, pushed it over the edge.
So you developed hypothyroidism, or you developed hyperthyroidism as part of it?
Initially hypo.
Hypo, okay.
Yeah,
and
but
so
with normal testing, but symptomatic.
You had symptoms of hypothyroidism, okay. And so why, my patient, my base is pretty well educated. I talk a lot from the lens of the cell danger response. Are you familiar with Robert Navio's work?
Yep.
Okay. So I talk about that from that lens. And when I read Navio's paper, I don't know how long ago it was now, maybe it's 10 years now, but that was an aha moment for me. And so when I read that paper, I was like, oh my gosh, this made more sense to me for what was going on in hypothyroidism. And what I was taught in school, regular education, and then in functional medicine training, is that the immune system loses control, it attacks the gland, and that's the primary issue. But I thought, man, that doesn't make a lot of sense, because why would the immune system wake up one day and start attacking us? And I thought there's got to be a different process here, because after years of working with patients with chronic health issues, what you find is as you address some of those root cause stressors, the thyroid physiology, without manipulating blood values with medication, we see this process of underconversion of T4 to T3 start to convert again. We see the immune response kind of die down, and we see a thyroid gland actually start to generate thyroid hormone again. So I was like, how could this be broken physiology, like an immune system out of control? And then I got Navio's paper and I'm reading, oh my gosh, okay, here we go. This is it. My buddy Ben Lynch sent me the paper and said, hey, you need to read this paper. And I read the whole paper and I see, okay, vitamin D in this situation does this, in this situation does that. And I'm like, okay, so everybody's not vitamin D deficient. It's what happens to vitamin D in certain situations. Everybody's not iron deficient. It's anemia of inflammation. We do different things with things. And so I read that whole paper, and thyroid physiology wasn't on there at all. And so I reached out to Dr. Navio and I said, hey, well, what happened to the thyroid stuff? He's like, you know what? He's like, Eric, I don't know much about thyroid physiology. And I was like, oh my gosh. And that's where my friend Ben said, you need to explain it, write it. So from my perspective, and I'd love to get your take on it, is that when cells perceive danger, part of what the cell does, the mitochondria, and for the listeners, cells, and I say this over and over, but I'll say it again, cells operate in really two modes to keep it simple. They're in low stress homeostatic mode, which is manufacturing mode. I'm bringing in lots of stuff and I'm making lots of stuff, hormones and enzymes and peptides and proteins, cell membranes and skin and hair. And to do that, I need a lot of T3 inside the cell to drive that energy process. Or a cell can sense danger, a threat, a toxin, a trauma, an organism. And when we exceed the capacity of the cell and we initiate this danger physiology, which is often kind of monitored by your mitochondria, we shift from manufacturing mode to danger physiology. And part of the process, and if you've read Navio's paper, he labeled out all those steps. And I think he forgot one really important one. And that is one of the regulators of all 8 steps, either directly or indirectly, that Navio talks about in his paper is the downregulation of T3 inside the cell. Because if I have less T3 inside the cell, I slow down the manufacturing process and I can ramp up defense. We often think that it's broken. I don't think so, because if I have a threat inside the cell, what am I trying to do? I want to increase reactive oxygen species. I want to try and kill whatever that threat is. And if I keep my mitochondria ramped up, now I've got free radicals from my mitochondria. I got free radicals from my defense mechanisms. I don't have the same, my balance with what I make from free radicals and what I make as antioxidants becomes out of balance. And now we can have more cell stress. So we see a lot of the literature. We talk about different aspects of that cell danger response and the downregulation of T3. In my opinion, and from all the papers I've read, is that many times that downregulation isn't broken, but adaptive. So from my perspective, hey, I got all these stressors building up, right? Accumulation of different stressors. I get a virus. Now I push the button that you said. Now I'm into danger physiology. And now I start to trigger that tissue hypothyroidism where I get signs and symptoms, but I still have at that point still potentially a gland that functions fine.
Yeah, and that's a beautiful, something probably one of the best I've heard, by the way. So kudos on that. But let me add one distinction here.
Sure.
When you're seeing the cell energy, and again, to me, it's a lot about energy. Certainly, there's inflammation, there's immune ramping up and down, there's innate immunity, and there's all these different things. But is it physiologic? Is it helping the cell or is it not? Is the cell dropping energy production to prevent an infection from hijacking the mitochondrial machinery to make more viruses and infectious organisms? Is it doing it on purpose? And is it in control of the process? Or is it a process that's gone awry, of shut down energy metabolism to starve the virus? Well, the virus is gone 10 years ago, but it hasn't clicked back on. So, there's distinctions. In other words, I'm going to go ahead with what I call the S.H.I.N.E protocol to optimize energy production again, turn the system back on, being conscious that sometimes the body may not want that system turned back on, and I've got to respect that because it'll tell me otherwise.
Well, yeah. So I think what you asked is the issue I'm stuck in that cell danger response and the threat is gone? That happens. Or am I in the danger response because the thing is still there? And
Is it helping, or is it a maladaptive response to a situation that's no longer there?
Absolutely.
Is it good to leave the body in the low stress and the low energy production and go after infections, go after different things that are stressing, and then to bring up the energy? Or is whatever triggered the trip circuit breaker long gone, and I just need to restore energy production, and then all the lights come up? And it varies from person to person. I got to look at the situation and tailor it case by case.
Oh, I totally agree with that. And that's the art and science of functional medicine, is saying everybody doesn't need more thyroid hormone in a certain situation. And if you give more thyroid hormone when the body really doesn't want it or need it, there's a huge risk of creating lots of problems. And that's been well documented, different types of cancers and everything else with people 5 to 10 years on thyroid medication. The incidence of many cancers is much greater, right? So go ahead.
Well, it goes back to what I said, which is it's not just the testing. It's not just listening to the person in terms of symptoms and timeline. The third thing is then the therapeutic challenge, giving different types of thyroid therapies or none, and seeing how they respond. Generally, although you can certainly override a defense mechanism that's needed, the body tends to tell me, I think, do they feel better with it? Is it a healthy energy, or is it, kind of a thing? So the response to treatment is a critical part of that triad. The testing, listening to the person, how do they respond to given treatment?
Yeah. And for the listener, we were talking about Dr. Navio's kind of paper on the cell danger response. You've heard me talk about that before. And Dr. Navio talks about a couple different processes. One's that danger physiology. If the danger physiology goes away, we should go back into a healing response. But some people get stuck in that in between the actual danger physiology and the healing response, and they're stuck there. And the way I try and explain it to people is, let's say somebody broke into your house, attacked your children, and you fought them off and got rid of them. Do you go back to normal operating mode tomorrow? And you probably don't. You'll probably double check your doors every day. You're going to still act as if for weeks, months, maybe years, even though nobody is breaking in and that was maybe a one-off situation, but we still act as if. And that becomes the problem. And it's kind of the way I explain it to patients, like the thing may be gone. And sometimes, as you probably know, that's really hard to get across to somebody because they think they have the constant thing, but the thing may actually not be there. It's the adaptive response that's kind of stuck.
Well, here's an analogy I give that sometimes people get, and I think different people hear different ones, is if I plug in too many space heaters on a cold winter night and I trip the circuit breaker, I can unplug all the space heaters and there's still going to be no lights. That circuit breaker is off.
Hmm.
And until I turn the circuit, sometimes some systems it may come back on its own. But a lot of people, you've got to go and turn that circuit breaker, the hypothalamic limbic system circuit breaker, back on. Or I don't care if you unplug all the space heaters. I don't care if your infections are all gone. I don't care if the initial things that triggered the cell danger response are gone. You have to turn the circuitry back on. And each person's different. But people kind of can get that. And um, and that's why I find that just doing a single treatment, it's usually you're going to find there's multiple weak links by the time a person at least has found me, because I'm harder to get to. Now I'm retired, so I'm a bit harder to get. But I find that treating the whole process and not just a single weak link gives the best result. Otherwise, it's like trying to pick up a boat by one end, the other end goes down. They feel better in the beginning, but then something else, some other link breaks.
So explain that a little bit more when you're saying that you need to treat when somebody's let's talk about the process. Well, we'll get to that in a minute. We'll try and keep this going in a kind of orderly fashion. One of the things you talked about earlier was maybe the connection between hypothyroidism, chronic fatigue syndrome, fibromyalgia. How do you see all those things tied together? I mean, I see reasons like I can do it, but I want to hear your opinion as to how do you see those all those things tied together? Because somebody might be saying, well, I've got a thyroid issue, but I don't have chronic fatigue. I've got fibromyalgia, but I don't have a thyroid condition. So what's the correlation that you see?
Well, on a simple sorting out who's who and who has what, it's a simple question. If you have fatigue, okay, and it may be severe, then it may be a primary thyroid process. Certainly the TPO is helpful. It'll look for immune issue, with Hashimoto's, the rest. But the simple question of can you get a good night's sleep is not 100%, but a pretty good discriminating question. If they come in and say, yeah, I can sleep fine, but I'm exhausted, then, when you wake up, are you refreshed? Yeah, I'm pretty refreshed, but I still overall have this overall thing. I'm going to be looking predominantly at thyroid or individual things. But by the time they say that they have the paradox of can't sleep even though they're exhausted, that tells me they have hypothalamic dysfunction. They tripped the circuit breaker. The sleep center is in the hypothalamus and the limbic system. I'll sometimes say hypothalamus, but it's that whole system. That's the sleep center. And when you get the paradox of can't sleep despite being exhausted, I'm going to be working on the probability that you've tripped that circuit breaker. We have to look at the individual downstream or initiating components, thyroid, adrenal, infectious, situational stress, all these different things that add up. It's called allostatic load. If I look at the total stress level on the body, internal and external, called allostatic load, in many ways, the body, it's just what the total is more than where it's coming from. And that's why when I gave the story in the beginning, I noted, yeah, I had this nasty viral thing. I could have left it at that. But why did that virus trip the circuit breaker in me? Because the allostatic load, stress level from all these other things set me up. And that's why the history and the timeline that we talked about is so important in getting a history.
Yeah, for the listeners, you've heard me talk about what Dr. Teitelbaum's talking about is like stress. I kind of explain it like two cinder blocks and a board going across. And as I go through life, I load 5-pound weights on that board, right? And sometimes I take some of those weights off, but a lot of times I just keep accumulating weight on that board. And if the capacity of the board is 100 pounds and I exceed the 100 pounds, the board breaks. What caused the board to break? And that's usually somebody says, well, the last weight you put on it. Really? If I take that 5 pounds, was it really it, or was it the load? So sometimes it's the chronic accumulation of stress without recovery, right? Without taking some off. It's okay to put 90 pounds of weight on the board as long as I take that off, or otherwise something very small stress could actually cause the board to break. I can also have real intense acute stresses that are not super big, but if they're really intense, that can also cause the board to break as well. So I agree. We have allostatic load, like it's more than the body can handle. And that's where I was talking about before. I have to change my attention from manufacturing to, we got a fire in here. Everybody stop working on making widgets. We got to work on putting the fire out. That becomes the primary issue. But when you talk about let's get into the sleep, because sleep's a huge issue. And you say when somebody is having a hard time sleeping, and we're gonna hear people say, well, I'm fatigued, I'm tired. What do you think is the big driver to sleep issues? Is it and it could be multiple things, but I think when a lot of times people don't know what to do. They're like, okay, so what is it? Is it an adrenal issue? We hear terms like adrenal fatigue thrown around. We hear people throwing all kinds of ingredients and herbs and supplements, melatonin, and all these things to things to help GABA to suppress sleep or to get us to get to sleep. But as a person who's kind of saying, hey, I've got this HPA axis thing that's kind of HPA, HPT, HPTA axis dysregulated, what do you think is driving the sleep disruption or reduced quality of sleep?
So again, there's a number of things. And again, there's a couple basic questions to start with that I think help break it into categories. Number one, is your mind wide awake and racing at bedtime? I'm going to start with a presumption that their cortisol, their diurnal rhythms off, their cortisol levels not dropping low enough at bedtime. I'm going to give them phosphatidylserine for a couple of nights. That will tell me if that's going on, because that'll put them to sleep. Are they waking up in the middle of the night with night sweats? Okay, well, I'm going to be looking for dropping blood sugar. How do I tell? I have them take a protein snack at bedtime. See if that helps. Do they have symptoms in labs suggestive, and it doesn't have to be both, of testosterone or estrogen or progesterone deficiency, or they're perimenopausal? What will tell me in a woman, not the FSH-LH, because that doesn't start dropping until 5 to 12 years into deficiency. What will tell me is around their menses, is there fatigue, headache, brain fog, and insomnia much worse? That will help me discern. Do they have candida causing infections and night sweats? Well, do they have nasal congestion, postnasal drip, irritable bowel syndrome? I'm going to treat for candida. Do they have, acid reflux? I'll give them a Tagamet or Pepcid, not the PPIs, which are poison, but the Pepcid or Tagamet. I'll give them that for 3 nights. If the night sweats go away, I have a diagnosis, then I can address how to treat each of these separately. Do they fall asleep easily during the day while watching TV or at the wheel? I'm going to look for sleep disordered breathing, things like sleep apnea or even narcolepsy. So I'm going to be looking for those kind of things. But at the same time, if they're saying that overall, I can't get restorative sleep, I have trouble falling asleep despite these initial things we talked about, I'm going to treat. I'm going to use things like EP120 sustained release melatonin. I like the higher dose now. I used to limit it to 0.3 of a milligram, but the data suggests to me I personally take a 10. Going to go with things like revitalizing sleep formula. I will go with medications to initiate sleep, Z medications in this disease, because they are often needed to help fall asleep. I will go with low-dose trazodone, Flextriol, amitriptyline, or other medications to help sustain sleep. But I'm going to use a low dose of several things, starting with natural things, using something if needed to initiate sleep, but otherwise using non-addictive components, and going with tiny doses combined so that they're not hungover the next day. And I'm going to see how they respond. But meanwhile, my main focus after I've done that initial thing to get them sleeping is what is taking enough of those weights off the board that their sleep control center can work. And I'm going to go with things like ANS rewire or dynamic neural retraining system as well. But again, sometimes I got to do the initial put out the fire. I've got to restore the physiology, and then I'm going to work to turn the circuit breaker back on with some of these other techniques.
Got it. So some of the things that you mentioned, though, are they really restoring quality sleep? Or are they just putting them into?
Sometimes one, sometimes the other. So I'm going to be focusing with things that the Z medications are pretty neutral for sleep. Zyprexa is probably one of the things that most increases the M3 deep sleep. It's a shame this treatment that most effectively increases deep sleep. This is the gamma hydroxybutyrate, which used to be available in any health food store, was cheap, safe, highly effective. So of course the government friggin' made it illegal. And the prediction was it would go from being this $20 over-the-counter safe thing to being stupid expensive as a prescription. It's now $250,000 a year. God bless our tax dollars.
Yeah.
But the outside of that, the main thing is avoiding medications that worsen, that put people in stage 2 light sleep. The Valiums and things like that, that actually worsen sleep quality. So otherwise, with what the government leaves left to us, we're looking at maintaining it and then going after the resetting that part of the nervous system so that the body can take over. So a lot of times, always can get them sleeping 8 hours a night, whether it's restorative sleep, most often, but not always.
Okay. And so there's people that sleep through the night. They get their 7 or 8 hours, but yet the next day they're tired, fatigued, and by 3 o'clock in the afternoon, they can't keep their eyes open, and they're looking for some caffeine to help keep them awake.
Mm-hmm.
If you've got them to sleep, but now they're still struggling with the fatigue during the day, and somebody might say, "Oh, that's chronic fatigue syndrome." What now?
Well, it depends. I mean, I'm going to look at the whole process of thyroid. I'm going to look at reverse T3. I'm going to look at, is there T4.8, where the normal range is 0.7 to 1.5? Are they in the lowest 5% of the population? That's not normal to me. An income of $8,100 a year is in the normal range. It's not in the lowest 2.5% of the population. But most people aren't going to live well on $8,100 a year, and as you'll, so, where they are in the range. And again, then I'm going to go with some of the simple things. I will give nutritional support. I talk about optimizing energy, what I call the S.H.I.N.E protocol, optimizing sleep. And if they're sleeping fine, then I may just leave that be. Optimizing hormones, especially thyroid, adrenal, reproductive hormones, although there's many others. I would be infections. And again, nasal congestion, postnasal drip, irritable bowel syndrome. I'm going to treat for candida. 6 weeks of diflucan, a good probiotic, and maybe something like berberine Med-X or grapefruit seed extract or something to, because
let's get into this. We'll cover the S.H.I.N.E protocol and kind of cover it systematically. So you have a person that comes into your world and they're tired and they're fatigued, and you're going to do your assessment, but you have the S.H.I.N.E protocol. So let's just talk about what that is, and then let's break down each of those components, okay? And that way we're kind of staying on a path. So you've identified somebody's got some chronic health issues. They got chronic fatigue, they're tired, they're gaining weight, they're not sleeping well, they're exhausted during the day, they got chronic pain. The vast majority of the clients that come in to my practice, I'm sure to yours, they've got a list of 30 different symptoms. They're on 20 different supplements, 4 or 5 meds. You're identifying, hey, this is a person who's got, I hate diagnosis like fibromyalgia and chronic fatigue. We're naming the signs and symptoms, but you identify that they've got a chronic health issue. They've got an energy issue. Where you're starting with this S.H.I.N.E protocol?
To me, the label serves to help tell me, do they have hypothalamic dysfunction and limbic system? That's the main reason for the label. I'm not averse to the label. The label is helpful. It's a syndrome. But what's critical then is to figure out what's causing the energy crisis that's triggering it. Now, there's people say, what test do you do for fibromyalgia to diagnose it? Nothing. I ask them, are you exhausted and have trouble sleeping and have widespread pain and brain fog? They say, yeah, you've got fibromyalgia. But I do extensive testing to look for the causes and reflections of that energy crisis to see what the weights are that are dragging them down that have to be removed. Because you mentioned the 25-pound weights that are on there, but there may be hundreds of weights in the world. I need to figure out which ones need to be removed from that board. That's their world, and which ones need to be addressed. And for that, for those of you who are practitioners, you can email me and I'll send you kind of a short form questionnaire, or if you prefer a long form, especially if you're an MD and you need to know all the other background history, which is helpful. You're a step up from an MD, but a lot of people The legal requirement requires that I know what surgeries you've had in the US. You need to know all that anyway for the timeline. But you can email me. It's fatigue, DOC, at fatiguedoc@gmail.com. Ask for the long form questionnaires, short form questionnaires, treatment checklists. All of this dramatically simplifies the intake, because I have the person filling out, instead of asking 150 symptoms, I'll have, here's the thyroid group, how many of those are checked off? Here's the adrenal group, how many of those are checked off? And, sleep disordered breathing, all of those. I can look at patterns on the checklist, and instead of taking an hour and a half to collect that information, it's there in 5 minutes. So I'm happy to give those for free and adapt them to your practice if you want. But yes, I'm going to sort it through this way, looking at sleep, hormonal, infectious, nutritional issues. I'm going to be, and the E would be exercise disabled, not too much, or they get post-exertional malaise, but enough that they don't decondition. That's a smaller but significant area, because it's turned into an idiotic thing of just exercise. And sometimes just go, it's off. The doctors that are saying that, but they can't. They don't have the energy to condition beyond a certain point. They crash. So enough to prevent deconditioning. But again, I will go ahead, and in the initial intake, I am looking at the timeline. Okay, to see what things came in around the time, and that's critical. I don't know how I do it without having that information.
Right.
But the questionnaire elicits all of that.
Yeah, and I think that's that's what we do in functional medicine, is really spend a little bit more time looking at health history, looking at timeline, trying to piece it together. At least that's what we should be doing in functional medicine, to try and figure out how we got here. But you do that piece and you go, okay, I got this going on. So my step one is, now this is a person who's got some sleep issues. I got to get them sleeping, because they can't heal and repair unless they're sleeping. So that becomes a priority, and you're going to use some lifestyle modification. You're going to use some supplementation, and even to some degree in your world, you're going to use some medications to try and get them at least a little bit better quality sleep. Right. And so that's
a lot better quality sleep.
Yeah. So that's step one. Right. And then you're saying, okay, now I've got to start looking, while I'm doing that, I got to look for those weights, right? So that I can deal with hormones and the other pieces of that S.H.I.N.E component. So you talked about testing. So what do you think are some of the key tests? And obviously we look at the health history, we look at the health timeline, and then we make the determination based on the individual. What are the key tests? But what do you see as a general rule for you? Like, hey, these are oftentimes the key tests that I need to look at to help identify some of those issues.
I have an extensive panel of tests that I do, and I'm happy to send the panel that I do for anybody who would like. For hormones, the key testing that I'll do for thyroid, free T3, free T4, reverse T3, TSH, TPO antibody, and probably a thyroglobulin antibody is reasonable as well. So I will be checking cholesterols and things like that, but there's a lot more. But for the quick snapshot, specifically for thyroid, for adrenal, I'm doing a morning cortisol. I used to do cortisone stimulation tests, and everybody don't need them anymore. The fasting morning cortisol and glycosylated hemoglobin. I know it's not a great screening test for low blood sugar, but it helps. I find it tends to correlate. They're running a glycosylated hemoglobin of 4.9. Diabetes is 7 and over. Most people run right at 5.5, 5.4. They're 5.1 or less. There's a really good chance they need adrenal support. They're 5.7 or 4.7 or less. They have a mitochondrial dysfunction. I'm going to be addressing that. So those two tests are really good screening for me for adrenal. FSH, LH, free and total testosterone, total estrogen, total progesterone.
So you're doing blood tests for your hormones, right? From a thyroid perspective, curious, did you leave out the total hormones on purpose, or is it something that you don't think is important for you? Why would you think that the total values of total T4, total T3 don't have a value for you?
They don't. It could just be my lack of an education in using them, but I find that most of the active hormone is unbound. Bound hormone's not very active. And the hormone binding levels and the rest, I personally just consider the free hormone levels to give much more of the information, and I don't consider the bound hormone levels to give enough for me to want to bother with the cost of doing them. They're not going to affect my treatment. At that point, I'm going to be looking at symptoms. The free levels can be totally fine, and I still may treat. In
Well,
fact, I often will.
I guess I see this more and more, people not looking at the total values, and we may, obviously we're allowed to have different opinions on it, but I think it's important to understand, do I have a person who has plenty of total hormone, right? And you're correct that the bound hormone doesn't have the reactivity. The hormone has to become free to get into the cells and tissues. And so if somebody has high total but low free, there's other questions we need to ask, right? Which is it, do I have low free hormone because I have higher binding globulins? Do I have low values because I'm not making thyroid hormone? Do I have low free hormone because I have high albumin?
If you have a high total, you're making free. But so the question is, when is it? And I'm not saying I'm right and you're wrong. I'm guessing here you're probably right. And this is something you've learned how to make use of, where I haven't learned how to make the use of distinguishing between the high total versus a high free or low free.
Yeah. So this is an argument. This is just a discussion back and forth to say, hey, why do you think it's not important? And you may say, hey, I just don't use it. That's fine. There's tests that I don't use, and because it doesn't have a value to me, and it's perfectly fine to have a value.
But I want to understand. But I want to understand for you, though, what you see the value is. You're a very bright fellow. You obviously know what they're about. So when you say you're doing something I'm not doing, I'm going to suspect it's because there's something you know that I don't, and that's why I'm kind of.
Well, here's an example, right? So you could have a. I look at hypothyroidism from two perspectives. Is it a glandular issue? I'm not producing enough hormone, or is it a peripheral tissue issue where I'm not converting it? Okay.
Or central.
Or it could be central because I got an inflammatory condition going on or a stress condition going on. In that situation, I'm going to increase the conversion of T4 to T3 in the hypothalamus. I'm going to saturate the hypothalamus. TSH is going to drop. My sympathetic nervous system is going to be upregulated, right? So in that situation, I might have lower hormone production because I have a TSH that's tending to be a little bit lower. So I may have lower total hormone production. I may also have low free hormone, but I have high levels of T4, but I still have lower free T3. And so then do I give more T4 in that situation? Do I need more in that situation, or do I need to address why I don't have enough free hormone? So you might say, well, just give more hormone. So it's got to become free at some point. The other issue is we could say, well, there's the gland's making enough. We need to understand, why is it not free, or why is it not being converted? So I think all the markers have a value as we start to interpret that, especially as we take a look at the rest of the labs. I do want to ask you about reverse T3 because that's pretty controversial. I think, what's the value to you about reverse T3? Because traditionally you'll hear people say it has no value. I think it has a value.
I think it has a definite value. The value is if it's high and they're not responding to desiccated or levothyroxine, but they have symptoms suggestive of low thyroid, and that reverse T3 is even trending high. I'm going to be looking at, Lowe's work was brilliant. And, I was looking at, is it a matter of decreased conversion of T4 to T3, in which case giving, 1 to 25 micrograms of T3 will have a dramatic benefit. Is it receptor resistance, where, it's going to be 80 to 125 before. And if I see the reverse T3 trending elevated in somebody with symptoms of low thyroid who's not responding to everything else, I'm going to suspect T3 receptor resistance, and I'm going to be willing to make them hyperthyroid on the lab tests. And let me give a wonderful piece of advice for those of you who are using high-dose T3. Have them, the T3 level is an utter useless piece of shit. if they're taking T3 by mouth. Number one. All it'll tell you is the time of day they took the T3, and it'll get you hung by other practitioners because they're going to see a high T3 and say you're making them hypothyroid. So if you feel the need to check a T3 level to make sure they're absorbing it, that's valid. But once you're clear they're absorbing it, if you're going to check a T3 level, or their other doctor says they have to check a T3 level when you're doing more than 25 micrograms of T3 a day, tell them to take the blood test before they take the medication for the day. So they're getting a trough level. It will be low. It'll drive their doctor crazy because, well, your T3 is low, but they'll leave you alone so you can raise and treat the T3 as you need to based on the symptoms. Or if that T3 is sky high because they're getting a peak level, they took it 2 hours after taking the thyroid hormone, there's some that'll go to the board and hang you. There's no benefit to that.
So I guess the question, there is that argument, well, okay, their T3 is normal, their reverse T3 is elevated, their T3, free T3 is low. So therefore, the reverse T3 is blocking T3 from binding to the receptor. I don't think that's true. Okay.
Yeah, it suggests to me that their body has a thyroid receptor resistance. I don't know that I buy the binding to the receptor issue, but that the body is shutting down thyroid production to conserve energy. Now, whether it's doing it physiologically because this is what it needs versus it was helpful, but now it's stuck.
So
that's
a lot of people would look at that reduced free T3 and say it's because they have a deiodinase 2 polymorphism, or they have an inflammatory process and it's causing a reverse. So if I give them a lot of T3, then it'll lower their reverse T3. Therefore, the T3 will bind and things will be good.
I'm simpler than all that. I give them the T3 and see if they feel better.
But I think I think a lot of people will feel better initially because the barrier to get T3 into the cell is a little bit easier. And if there's upregulation of deiodinase 3 that's decreasing T4 to T3, you're still getting deactivation of T3 by the same enzyme that's in there. So you're going to have the initial boost because you can deactivate T3 with deiodinase 3, but you get T2, and T2 can kind of act as a backup to support some of the mitochondrial function and physiology.
What I'm going to say is we're having a conversation on a level of physiology that we are guessing. It all sounds very,
I don't know that. I think we're starting to find those things out.
I think we're starting to, but I think our ability to steer the car predominantly on that kind of information, I am happier to look at the simpler information. I'm not saying I'm right, but I'm saying what works for me in my practice is to give a therapeutic trial, see what the clinical response is. Now, what I'll find is those who need the high dose T3, again, I'm checking DEXA scan first because I don't know why, but a lot of people who have elevated reverse T3 have osteoporosis or osteopenia.
Well, I think that's probably part of the inflammatory process, wouldn't you think?
May well be, but it's something we see commonly, and there are doctors who will be happy if they have the osteoporosis and you did not do a baseline DEXA scan. They will blame the T3 you're giving for that. And if you have the baseline DEXA scan, you can say, well, this was present before treatment. There are times, then you can treat, not give the strontium generally, unless they have a clotting history, phlebitis history problem. But then if I know it's there, and I don't see that it drives down the bone density much, but it's a good idea to check a DEXA scan before going with T3 over 25 micrograms a day, in my opinion. But what I find is after about 9 months of feeling healthy, what will often happen, not always, is that people will start to feel worse. And that tells me, in my worldview of things, that the resistance is reversing, and they need to lower the thyroid dose. In the beginning, when I first give T3, they'll often feel better, and then their body will adapt, and they'll go back down, and I will continue increasing it. But after a month or two, and especially after 9 to 12 months, if they're sailing along doing really well, and suddenly they're starting to feel worse, that's time to lower the T3.
Oh,
in my experience.
I would agree, and that's the case with either T4 or T3 many times. As you start to address the root issues, you're finding that, hey, I'm doing better. You reduce the dose, I'm doing better. Then all of a sudden they're like, okay, now I'm not feeling as good. You look at their labs and you're seeing, okay, it's time to reduce the dose. So I've driven that TSH too low. So you're
I,
looking.
I don't buy the TSH. With the hypothalamic dysfunction, a low TSH is very common in the people I treat with hypothyroidism.
Well, if you have inflammatory mechanisms still going on, but if you're part of what you're trying to do is to address the root causes in the inflammatory mechanisms going down, you have less inflammatory drive at the hypothalamus. So if that's going down and you now have more T4 into the system than you need, TSH is going to be suppressed because you have more T4 in the system than you need. So the TSH is giving you an indication that you have hypothalamic saturation of T3 because of too much T4. The other factor that's going to play a role there, if you have too much T4 in circulation, you're going to downregulate deiodinase 2. You ubiquinate it. So you deactivate it in the periphery. So you're going to get lower T4 to T3 conversion. So whether you look at it or you don't look at it, but that's typically two of the reasons why, hey, when I'm taking more medication than I need, it creates an issue, especially if you're trying to get your thyroid gland to actually do some work. You don't want to be suppressing the TSH too low because that prevents it from working. So
I'd say we agree for part of it. What I'm saying is that the TSH being low can, of course, suggest that the thyroid's too high, but it can also suggest that the thyroid is too low because of central hypothyroidism. And now whether the hypothalamic dysfunction then is part of the cell danger response and being triggered by blah, 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 and all the rest, maybe. But I'm saying clinically that there are those with low TSH who need more thyroid. And for me, I'm going to look at what symptoms do they have and how do they respond to treatment. I'm kind of an old-fashioned kind of guy. I just look at what works, what's suggested, but I realized I don't know. So
yeah, I think I would agree. I agree. You can have inflammation, and now you've got that upregulation of T4 to T3 in the hypothalamus, and TSH is going to be low. And because of that, that person's going to have low T4 production, and they may actually not be making enough hormone. And that's maybe one of the reasons why you're looking at the reverse T3 as well, because if you see that low TSH and a low T4 and a low reverse T3, then you're going, okay, this is a person who doesn't, and if all the hormones are, if T4, T3, reverse T3 are all low and TSH is low, somebody who's not looking at the rest of the panel might say, this is a person who's hyperthyroid because their TSH is low. But again, what gets measured or gets managed, you don't measure it, you can't see it, you get the totally wrong conclusion, even though you're looking at a patient with hypothyroidism.
Or this is somebody who's taking T3 hormone and got a trough level.
Right. And that's part of that's part of the interpretation of what's going on, right? So we have to assess. So we talked about sleep. We talked about
let me add
looking
adrenal.
at hormones.
We looked at thyroid, and we talked about the reproductive hormones. Where are the symptoms worse around the menses? Then I'm going to suspect perimenopausal. I'm going to consider the hormone treatments. In men, testosterone level under 540 or 500. If they're having symptoms of erectile dysfunction, metabolic syndrome, I'm going to consider, if they're younger, I'm going to go with clomiphene, 25 milligrams every other night, Monday, Wednesday, Friday, to stimulate, although that's not available right now. The company's not making it, or testosterone, just in brief. But for adrenal, if I had to pick the one thing that I find most helpful, it's the question, do you get irritable when hungry? And if the answer is yes, which is low blood sugar, and it goes away when you eat, I would not trade that question for all the salivary or blood levels in the world, the ionized cortisol, 3 totals, none of that. Irritability when hungry, I'm going to treat with adrenoplex, which is a mix of different, there's all kinds of things, the licorice and adrenal glandules would be 5 to C, but most of you have your favorite adrenal support hormone. The adrenoplex is mine. And I will consider low dose cortisol up to 20 milligrams a day. which I find to be pretty safe. And this, and the study, one of the studies we published, we actually did pre and post cortisone testing, and did not see any suppression of the cortisol of the adrenal at levels up to 20 milligrams a day. Of course, the NIH did a study that was run by somebody who has a reputation for never going to any of the conferences, never consulting with anybody who knew a thing, and never having a positive study. So he immediately went to 25 milligrams and saw suppression. So we know, as predicted, that cortisol up to 20 milligrams a day, I've not seen suppression. 20 over 20 will. But then irritability when hungry, I will consider adrenal support. And in some cases where I think the HPA axis is in the tank, I will consider the cortisol up to 20 milligrams a day.
Are you looking at ACTH before you make some of those conclusions? Yeah.
Of course.
And then can you kind of, you talked about cholesterol before. What do you look for from a cholesterol perspective? Do you consider cholesterol when you're looking at adrenal function and somebody's got low cortisol, low DHEA? Are you looking at their cholesterol levels and making an assumption or assessment of what might be going on at the adrenal gland?
The cortisol to me is I mean, the whole use of statins in people without underlying heart disease or angina is not that high anymore, but a $29 billion a year scam, as far as I'm concerned. So I'm going to check the cholesterol not for that, but if the cholesterol is high, and I'm going to be looking for insulin levels, or do they have insulin resistance, in which case the testosterone is often low in women, I'm sorry, in men, or high in women. I'm going to be looking at it for that. But it's not uncommon. I see people with cholesterols 100 or less with this disease. And that suggests to me the question of an underlying viral infection that's blocking the pregnenolone pathway and blocking the cholesterol production pathway. So although you can look at it for what it's saying about thyroid, what it's saying, I think we're saying the same thing from different angles, where I'm seeing that certain viral infections will block the cholesterol production pathway, just like the statins will block that pathway. I suspect you're saying that the cell danger response or inflammatory disease may block that pathway. And so we may be, and I may be mishearing what you're saying there, but.
Well, I think when I'm looking at, I'm just trying to get how you assess it and what's going on with the adrenal gland. Obviously, you're doing your challenge and listening to symptoms, but you had mentioned cholesterol before, and you take a look at it. I think we can take a look at low cholesterol as a potential problem from adrenal physiology, because
Absolutely,
if you have low cholesterol, an adrenal gland in acute stress makes its own cholesterol, but it's a short phase, right? But under homeostasis or chronic stress, where's the cholesterol coming from? We're bringing that into the adrenal gland, and we're bringing that cholesterol in. The receptors obviously are T3 driven to help bring that cholesterol into the system. And then we have to move that cholesterol through the mitochondria to actually work on making our hormones. So if we have low cholesterol and we have somebody with low adrenal DHEA, low hormones, low cortisol, hey, I've got a problem here. I don't have enough starting material.
Yeah, and then get a pregnenolone level. It is so often non-detectable or very low.
Yeah. So
which to me is part of that pathway you're talking about.
Absolutely. And for the listeners, cholesterol into the mitochondria, we convert that to pregnenolone, and then pregnenolone we can make into a bunch of other stuff. But if you don't have the starting material, it's a problem. The other issue is if you start seeing T3 stacking up outside in the bloodstream, we also aren't getting it into the gland to do a good job of making that into hormone.
Into the cells.
Yeah. And so, and the other because this is the Thyroid Answers podcast, keep in mind, if you have a low T3 state inside the cell, those LDL receptors, HDL receptors, it's thought that you need T3 for those things to function well. And what you need a higher state of T3 inside the cell to drive mitochondrial function, to turn the cholesterol into that pregnenolone. So when that elevated, if you've got adrenal issues going on, those are clues that as your docs should be looking at and saying, oh, wait a minute, we're too low here, we're too high here. Not that we need to suppress cholesterol. We need to be asking, why is it not getting into the cells and tissues where it belongs? Or why are we not taking that glucose and converting it into cellular energy, pushing it out of the cell, but not able to either get it into the tissues to use it effectively or get rid of it?
Interesting.
Right.
Thank you.
Okay. So we've got
the hormones.
Yeah.
And we can talk about hypotension too, which is the orthostatic intolerance, with the autonomic dysfunction, especially long COVID. That's really major. That's a whole nother 2-hour show to talk about. I have an information sheet. If you email me at fatiguedoc@gmail.com, I'll send an information sheet on long COVID and fibro, but also another one on there's 2 tests that will easily screen for orthostatic intolerance. And then it's just the orthostatic intolerance information sheet. You can do the 10-minute pulse test when you stand up. You can do a simple questionnaire that was out of the Mayo Clinic Journal, 2 nice, simple screens. And then it'll talk about here's how you treat it. Whether you're doing, so that orthostatic intolerance, it's a big piece of the autonomic dysfunction. It's just easier just to have the form and people can look at it if they're interested.
So just explain, because some people may or may not know what orthostatic hypotension
we are
is.
a big bag of water. When we stand up, what do you think gravity is doing to all the blood and the fluids in our body? It sends it down to our legs. And we had to develop to become an upright species. The autonomic nervous system had to develop the ability to contract the vessels and rest and send that blood back up to our brain, heart, and muscles. And when that autonomic system is not working well, especially in post-viral CFS, the blood goes down to the legs and stays there. And people may get a little dizzy in the beginning, but they'll get brain fog and fatigued after about 5-10 minutes of standing, and they'll feel like utter crap. And the doctors will miss it. They just don't know how, they don't even think to look for it. But you can have people lie down and check a pulse and a blood pressure and have them lie down for 10 minutes and stand up in one place. They can do this at home and just check their pulse. If it goes up, and my definition, more than 25 beats a minute, anytime in that 10 minutes when they're standing in one place. Or with COVID, we're seeing more that the blood pressure will drop, not just the pulse going up. If the blood pressure goes down, but mostly it's a pulse, then I'm going to treat for orthostatic intolerance. I'm going to treat to support their blood pressure when they're standing up, so the blood doesn't pool in their legs and stay there.
Yeah, and for somebody who's taking blood pressure medication, this is, I think sometimes we look at high blood pressure as the problem. Obviously, it's problematic, but what we really need to do is ask the question, why does my body feel the need to increase my blood pressure? And if you think about why, because it's trying to get blood flow to the extremities, and your brain is one of them, right? So when you stand up, you need to perfuse the brain. And if you get that dizzy and lightheaded, as Doc said, you're not getting blood flow to your brain fast enough. And that's why you get dizzy and lightheaded. And for the person on a blood pressure medication, you have to be really cautious, because
especially now that there's no such thing as too low a blood pressure in doctors' minds. There's medications to be sold. Damn it. Get them down to 90 over 70.
Right. Yeah. So
please excuse, I get a little passionate about some of this, but it's crazy.
And that's, so, and why do we do that? Well, because we lower the blood pressure and we still have people dying of cardiovascular disease. So let's just make it lower and lower and lower. We do the same thing with statins.
Because the committees that determine what the optimal practice is, and this is shown in the research and the studies, the companies that give the most money to those, the Endocrine Society, the Heart Association, they get their employees, esteemed professors, all I'm sure, that are on their payroll, sit on the committees that make the statements of what's optimal. And once you have that, an expensive medication for it, there's no such thing as too low a cholesterol, no such thing as too low a blood pressure. It's all about the money. These are all good people, but it's a system that's horribly broken.
Yeah. All right, let's get on. We got 3 more letters to cover in about 15 minutes. So let's talk about eye.
Eye is infections, viral. Do they have a viral onset? Viral, do they have chronic flu-like symptoms? I'm going to consider that, especially that seem to come up with symptoms. There are many things that when the immune system goes down, we're seeing it with long COVID now. It's associated with viral reactivation of Epstein-Barr. But you're saying, whoa, I checked the Epstein-Barr antibodies. They're elevated. Yeah, they're elevated in 95% of the healthy adult population. Does not mean jack. Doesn't mean a thing. Now, you can take a look at where and how high, but it doesn't mean much. More on the HHV6, I'll check the IgG, the Epstein-Barr IgGs, and the IgMs are useless. It's funny, I've seen 2 people positive Epstein-Barr IgM, and those are the ones that don't respond to antiviral treatments. Go figure. But again, viral onset, symptoms, flu-like symptoms when their symptoms flare, I will make sure their adrenal is addressed because those are very commonly low adrenal. I will go with Famvir plus Celebrex. 6-month protocol works very nicely. There are other, viral protocols, but that's the one that seems to work the best. Antibiotics, I don't make a diagnosis of Lyme much because our tests suck. The standard Quest LabCorp, the British Medical Journal described those tests as, quote, you may as well just flip a coin. They're that useless. Okay. And some of the holistic tests in my 45 years now in medicine, 50 years since medical school, I think I've seen 2 negative tests using the most common holistic lab, which suggests that the specificity is, when everybody has it, that's not reliable. So I am more likely to go by the symptoms. The checklist will have Lyme things, certainly the bullseye, but most people don't have the bullseye. But I'm going to make the diagnosis commonly not so much of Lyme's as much as antibiotic sensitive. And certainly the whole ILADS approach is a very important one. The home Lyme literate approach. But I'm going to recognize the limitations and make the diagnosis of antibiotic sensitive. And if they have chronic lung congestion, scalp sores, those people respond to Zithromax for some reason. But I will give a therapeutic trial. That they respond to doxycycline does not necessarily mean they have an infection. Doxycycline shuts down microglial activation, whether or not infections are present. It's anti-inflammatory. But if they respond to antibiotics, I will give them. And I have symptoms that I'll look for, for each of them. But the most important one to me, or very important, is the Candida. There's no test that I would give a nickel for to diagnose Candida overgrowth. If they have nasal congestion, postnasal drip that's not seasonal, or irritable bowel syndrome, gas, bloating, diarrhea, constipation, especially if the gas doesn't have much of a smell, but there's enough to fill up a weather balloon, I will treat for Candida. I will not bother testing because there is no useful test. There's plenty of tests, but none that I would pay a nickel for. I will give the diflucan. I'll use ITC pharmacy, compounding pharmacy, sinus nose spray. I will give, say, a berberine Med-X or grapefruit seed extract, whatever, good probiotic. I will give that for 6 to 8 weeks, and the effect is dramatic. At about week 5, they start improving if they have the Candida, and the sinusitis goes away, and the irritable bowel syndrome goes away. So those are the main eyes for infection. Certainly, there's a bunch of others, but those are the key ones.
Okay, and then we're down to N.
And nutritional support, what vitamin and mineral do they need? All of them. The American diet sucks. Half the vitamins and minerals literally are lost in food processing. What's left is the calories. We have 140 pounds of sugar per person per year, 18% of calories from white flour. Half the vitamins and minerals are gone. And these are catabolic conditions where people need higher levels than the RDA or ridiculous dietary allowances. I will give a good multivitamin. I like Clinical Essentials, although it's a little low in zinc, so I'll add zinc to it. Basically high B vitamins, high magnesium. We've published 2 studies looking at the effect of ribose decreases energy an average of 61%. So I'll give 5 grams of ribose 2 to 3 times a day. A recent study we have published on HRG80 red ginseng. It's a unique form of ginseng. It's the only one I found that really works. If you look at my desk, there's one thing that I keep sitting on my desk, and I get the chewable tablets. You can get it from Euromedica. It's red ginseng energy is what it's called. You can get it at Emerson Ecologics. Dramatic improvement in energy with people. Tastes good. My inner child goes, give me, like it. Uh, it's brilliant. Works really, really well. Coenzyme Q10, but I'm going to use one with gamma cyclodextrin that increases the absorption. Um, so simple things, B12 shots, yada, 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 yada. Most of you out there listening, you already have your own nutritional recipes. These are the things. But HRG80 red ginseng, the Smart Energy System is on Amazon. It's not sold to the practitioners yet. It has a mix of ribose, ashwagandha, rhodiola, green tea extract, a number of things that we did another study that we recently completed with that. That one's not published yet. Stamina went up 80% on average. So there's a lot nutritionally that feeds the mitochondria, feeds the cellular energy.
But do you
And
see we get into a trap
Hmm?
because what I see a lot is people read a book, listen to a podcast like this, hear somebody
Mhm.
say this and that and this and that. And then before you know it, they're taking 30, 35 different bottles of supplements per day, thinking that supplementation is going to be what fixes them.
Let me add one thing. If it's
Sure.
not helping after 4 to 6 weeks, stop it. If you're not
Yeah.
sure, stop it all. See if you're no worse 4 weeks later, you're none of them. But
Yeah.
stay on the multivitamin, the B vitamins and magnesium, just as a critical baseline. All the other stuff, you know, see if it's how it's working for you. And if you're not sure, stop it and then restart it one at a time.
Yeah.
I do that every so often. People come in with the shoe boxes of stuff, and I break it into keep this, toss that.
Yeah.
And this one, if we find it helpful, so yes. But also cut sugar, increase salt intake, increase water intake, even though you're already drinking like a fish, and high
Yeah.
protein
Well,
in most people.
part of the reason I think people are afraid of salt, right? But salt, I think, is critical. And
It's
most
healthy.
people, if they're having adrenal and renal issues, they're losing their sodium. So I think,
If you're salt restrict, you'll crash and burn with this disease.
yeah,
And high blood pressure, which you will have. The studies show if you salt restrict to the most intolerable level versus the highest level of salt that people do, you drop your blood pressure less than 1 millimeter. If you're black, then you drop it 2 to 3 millimeters. Salt has a minimal effect on hypertension, but the myth persists despite that. Say, well, if you have 200 million people, that 1 millimeter translating up, taking
yeah,
the kiss off.
right.
It's a potassium deficiency. Hypertension is not a salt excess, and you need the salt.
Yeah. Well, yeah, I think that's it's in one of the many myths that we continue to carry through is that salt's the big,
Salt's bad, eggs bad,
yeah,
chocolate's bad, coffee's bad, tea's
yeah,
bad. All of
fat's
these are
bad. Yep.
healthy. Yeah.
Yeah. All right. So we talked about nutrition. I agree. And for the listener, I've said this over and over. If you're taking, I say this to my clients all the time. If they're coming in with a boatload of supplements and they still don't feel well, I usually say if you need, 15 or 20 supplements to feel this bad, you probably don't need any. And what you probably need to do is start over. And I know we get very protective of our supplementation, right? We're clinging on to something. I heard this should work. I'm afraid to leave it go because I could get worse. What sometimes we don't realize is that over supplementation may actually be part of the problem. And you know this too, from years of practice. We see, and even Navio talks about that in his paper, like under certain conditions, we assume that what we give is going to do what we want it to do, but the cells are going to use it to what is the most important for them.
And let me mention something, Eric. The whole issue of methylation. Again, methylation is an important cellular defense, blocking methylation to starve the infections. But looking at the blood test to see if you're heterozygous, that's, for a methylation defect. That's not a defect. The majority of the population has those defects. That means they're variations, not defects.
Yeah, listen, I agree. Everybody's making money on genetic reports right now and saying you need this supplement for this SNP, this supplement for this SNP. And
It's
That's not
bullshit.
true. Yeah. And so the bigger player, especially for the person who's hanging their hat on their genetic polymorphisms, as you were, I think what you were alluding to, for every polymorphism you probably have another polymorphism somewhere along that pathway or chain that supports it. But the bigger influence, the things that you should be more focused on, is the epigenetic influences, the diet, the lifestyle, the things that affect it, and be super cautious. Most people want to provide the thing that's supposed to make the gene work better. And what we probably need to spend more time on is the things that are inhibiting that gene or slowing that process down versus the things that, oh, just give more B6, just give more B12, because that can oftentimes create an issue or problem. So we've got nutrition down. We've got a couple more minutes. We've got one more. It's E. What is it?
Exercise enough, walk enough to prevent total deconditioning. Don't walk enough to trigger post-exertional malaise, of course. But again, a lot of people with the disease, because you get that, you feel like you're hit by a horse and you're bedridden for 3 days. If you ever push it, they're afraid to do anything. That's understandable. But the crashing is not harming you. You just don't want to crash. You don't want to put your body through that. But if you don't do any walking because of that, you'll decondition, and that will make the process worse. So see how much you can comfortably walk, leave it at that level. After 12 weeks on the S.H.I.N.E protocol, energy production starts to skyrocket. Most people find they can increase their walking by 50 minutes every day, 50 steps every day, or 2 or 3, as feels best for you. But what I'd like to do, Eric, is use the last thing to give an important thing in terms of setting boundaries and learning to say no, because that's a critical part of what causes human energy crisis. Yes, it can be infections and the rest, but a big part is we'd like to be good boys and girls and do what we're people pleasers with this disease. And again, if you think, well, being a good citizen or caring friend, I'm going to do this. No, see how things feel to you. If somebody asks for something and it feels bad, as a doctor, you can use me as the excuse. The doctor said I need to say no. So, and because you'll see these little energy vampires out there, they're not bad people. They just learn that, they can suck you dry and toss all their emotional toxic waste on you, and you feel like crap, and they go, okay, I feel so much better, and if you don't say no, why should they stop? Don't let your mind tell you when to say yes or no. See how things feel. If something feels bad, remember, no is a complete sentence. That's the only justification you need, is that something feels bad to you. Unless you're going to get arrested or homeless for saying no, just try it for a while. And that's called setting boundaries and respecting yourself. Say yes to things that feel good, no to things that don't, and then see how that works out for you. This will always be one curmudgeon will say, well, heroin felt damn good. Yeah, but it doesn't work out for you very well. So how does it feel? How does it work out for you? Start setting boundaries and you'll feel so much better.
Yeah, I think a lot of times that we consider when we have chronic illnesses, we're looking for the thing that's getting us, right? The organism, the bug, the toxin, right? And I think oftentimes we don't realize it's our simpler things: disrupted sleep, it's our emotional stress, our trauma, our thoughts, our habits, our behaviors, simple things, the low-hanging fruit things that we can often address. And we don't, because we do them every day, we consider that that's normal, right? And we don't realize, no, I'm easily overloaded with stuff. And I'm a great example of how we can get there with when I found out, in my 40s that I had insulin resistance and Hashimoto's and elevated lipids. I'm like, how can that be me? I'm doing all the things that I'm telling people to do, but I really wasn't. I was sleeping 4 hours a night because, hey, I got stuff to do. I'm training a couple times a day because I'm doing triathlons, right? I am working all day. I'm studying, I'm researching, I'm coaching kids sports, I'm being a dad, a spouse. And you can't keep going. Exactly what you said. It was go, 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 but no rest and recovery. I didn't feel bad, but meanwhile, my body is shutting down and having a crisis. I
Yeah.
just wasn't paying attention to it.
And Eric, I'm going to speculate that if you had taken a moment before going to that meeting or this practice and the rest to see how does that feel, and said yes to the ones that felt good, and said no to the things where it was expected, but not, you weren't going to get arrested or homeless for not going. Well, gee, I missed that teachers meeting, a waste of everybody. I mean, I have 5 kids too. I get it.
Yeah.
Try learning to see how things feel. If it doesn't feel good, just give yourself a pass.
Yeah. And would you say, I think the other thing to tie into that is sometimes it's better to make a decision faster than to contemplate. I think the contemplation creates, oftentimes for many people, they're afraid to make the wrong decision. So they beat themselves up over and over and stress themselves out. Um, my simple rule is make a decision quickly.
Yep.
50% of the time you're going to be right, and 50% of the time you might be wrong.
And if
But
you just listen to your gut, you'll find those numbers are in your favor.
yeah, and if you make a decision and it does, and you go, man, I should have done something different. Great. You learned something and you move on and you can make a decision and make a correction and do better. I think it was John Maxwell who has a great book called Failing Forward, which is, hey, make decisions. If you fail, use that as that failure as a learning a tool to make better decisions later.
Success comes from successive failures.
Absolutely.
Yeah.
So it was a good conversation that we went through. Hour and a half went by pretty quickly. So what I want to do is I want to kind of finish up with you, let people know what you have out there, where they can find more information about you.
Well, the book From Fatigued to Fantastic, the blue cover edition, get on Amazon, has everything we talked about today pretty much, but even in more clinical detail of how to get from where you are to feeling fantastic. And it goes through each of these different things, including the mind-body components and the rest. It will talk about the thyroid in detail. It'll talk about the different issues of the different types of thyroid, and not quite the biochemistry in terms of the adenases and the rest, but in terms of what's clinically will guide you. My email address is fatigue, F-A-T-I-G-U-E, D-O-C, like doctor, fatiguedoc@gmail.com. You can ask for the information sheet. Some of you have infertility. You can ask for the infertility information sheet. Those of you with chronic fatigue, fibromyalgia, long COVID, just ask for the CFS or fibro fatigue information sheets. And I'll send the orthostatic intolerance sheet with that because they too often go together. My website for information is vitality101.com. My website for supplements is endfatigue.com. But at the end of the day, if you use this information to get better, so you can go back to a life you hate, neither Eric or I have done a thing for you. If you use it to keep the things you love and to cut loose those things, your psyche is saying, we have outgrown these things, then I feel like this time has been very well spent, Eric.
Absolutely. Well, I appreciate you coming on the podcast. And I did read the book. I got a copy of the book from your gang and I read through it. And I think you give a lot of helpful and useful tips in there. And I think it's written for somebody who doesn't have a physiology background to be able to look at it and say, okay, I can learn something from this. But I think you also put enough sciencey stuff in there that somebody who's in the biz can pick up some of the stuff without it going, this is too simplistic. So I think you did a good job putting it together. I appreciate you coming on the podcast. And for the listeners, share this one with friends and family. Even though we're talking about thyroid physiology and fibromyalgia and chronic fatigue, really, these are everything that we kind of talk about is about health and wellness, right? And so healthy eating, good nutrition, good sleep, good respiration, good mindset, all these are things, it doesn't matter what you're diagnosed with. All of these things, if you improve your level of fitness in all of those categories, you're going to be healthier, better overall. So don't worry about the condition. Just follow basic, simple lifestyle factors and improve those. And if you do those many times, you don't have to reach out to us for help. You're going to wind up fixing because it's faulty diet, faulty lifestyle, faulty nutrition, all those things that become the weights that break your board over time. So Dr. Teitelbaum, thanks so much for coming on the podcast, and maybe we'll get you on sometime in the future. Okay.
If you want to do on pain management, let me know. Eric, everybody, be well.
Take care.